Good afternoon, everybody, and thank you so much for joining us for another one of our wonderful MAG sessions. Today we have a Meet the Specialist session with Dr. David, Associate Professor Szmulewicz. Did I say that properly?
You did really well. Full marks.
Thank you. He is a neurologist and a neuro-otologist, which he's going to tell you about in a moment. He has been with us for a little while and writes an outstanding report. We are so pleased to have him on our MAG expert panel. If you would like to have a book with him, you can contact our team by the phone or on admin@medicolegalassessmentsgroup.com.au, and our team will find out his availability and make that booking for you. Pardon me, this session, like all of our sessions, will be available on our MAG YouTube channel for you to watch. And for those of you who register for the session, you will also receive the recording within a couple of hours or so. Anyway, thank you so much for making time to join us. There will be time for questions at the end of his brief introductory chat. And we look forward to seeing you again in our next one. So over to you. Thank you so much, sir.
Thank you very much, Michelle. So as Michelle said, I'm a neurologist and neuro-otologist. So my work involves general neurology, which I think a lot of you would be aware of. But as a neuro-otologist, I subspecialize in disorders of balance and coordination. So my clinical work involves conditions such as movement disorders, disorders of peripheral nerves, the spine, balance, coordination, etc. In my medico-legal work, again, I see all comers in the field of neurology. My special interests are in traumatic brain injuries, spinal injuries, and injuries of peripheral nerves. So these are the nerves that carry the messages in and out from the extremities to the spine, and are not uncommonly involved in workplace and traffic accidents. So my experience is in IME, JMEs, working with TAC and work cover, as well as other private providers. Part of what I aim to do in my reports is to offer an explanation for my opinions and explain any impairment assessments, but I am always very happy to be contacted if further explanation is required. And the other thing that I try to do is I understand that this area can be a bit confusing because you have neurologists, neurosurgeons, neuropsychiatrists, neuropsychologists. And so I see part of the role for neurologists is in guiding the customer to understand which of these specialists may be required. And so in addition to the ones I named, there are also orthopedic surgeons, general psychiatrists, and as many of you would be aware, there's often a significant overlap in any material injury, but particularly for traumatic brain injuries where we obviously share an organ with psychologists and psychiatrists. And so it's not uncommon for there to be neurological as well as neuropsychological and neuropsychiatric manifestations. And where a neurological report requires that extra input, then I try to make that very understandable and explain why that's required and how it will help me or another neurologist reach a conclusion where they can give a definitive opinion and or impairment rating. So I'm available for in-person consultations as well as telehealth. Naturally, there is some limitations with certain neurological cases where telehealth is concerned because we still rely a lot on the physical examination. We're still a fairly hands-on specialty. There have been some technological advancements, and this is part of the research area I work in, which is in developing devices for disorders of movement. My other interest is in teaching. So I teach medical students, medical specialty trainees, allied health trainees, as well as pure clinical researchers.
Great. I actually have a couple of questions that have come to me from people who've been unable to attend. I wonder if I can put those to you.
Absolutely.
Okay. And you touched on it before in relation to the peripheral nerve damage. And one of the clients said that they have a person who worked in an industrial kitchen and sustained a burn to their hand. And that has resulted in the person having a lack of sensation in their hand as to when they might be at risk of burning it again, or indeed cutting or damaging their hand. And they wanted to know, there's two parts to the question. Is that something that can ever resolve, is the first part of the question. And secondly, what are the things that a person would have to put in place in terms of other therapies or any other activities or actions to manage that moving forwards?
Yeah, it's a great question. So it depends on a couple of factors, and those are the depth of the burn, the physical area of the burn, so how large is it? And underlying part of that is really which nerve structures have been involved, and that will very much decide the degree of what we call sensory impairment, so how much the person cannot feel or can feel, but it's modified. They're not getting full sensation. And additionally, time. So in terms of recovery, we do, depending on the depth of the burn, see a degree of sensory recovery, but it's slow. It may be 6 to 12 months. If the burn is of an interim or significant depth, then we only expect very limited recovery, and usually around the periphery of the area. And I think part of what the question raises is the issue of safety, because we very much rely on sensation to be able to operate normally. So to be able to hold something, we need to be able to feel it, but we also need to be able to feel potential danger. So if something is hot or sharp or moving or slipping through our hands. And again, depending on the area that's involved. So if it was, for example, the palm of the hand, it may mean that there could be significant restrictions for the use of that hand. If, for example, it was on the dorsum, so the upper surface of the hand, then that would probably have less of a functional effect because we rely much less on sensation in that area to be able to perform our usual activities.
Right.
And the other factor to take into account is if it was an upper limb, whether it was a dominant upper limb, because that will also have a significant influence on whether a person can return to their normal duties, whether in fact they can return safely to modified duties. So I mean, it's a difficult one to answer directly and definitively, but they're the considerations that we would be making when we were asked to examine someone who had a burn or a damage to the skin otherwise. I mean, it could be a significant abrasion following a motorbike accident, for example, or an injury that required a skin graft, which is not at all uncommon.
Right. Yeah, good point. Vina, did you have any questions that you would like to ask? No, it's okay. Not a problem. I have one more question before we let you go, sir. You mentioned as well TBI.
Yes.
Obviously, all forms, even mild traumatic brain injury and CTE
Yes.
are coming in more often. Is that something that you are seeing more of? And I wonder, whilst we see the high profile stuff about footballers, of course, I'm wondering about things like, for example, bus drivers or people who are driving a vehicle all day, every day, where they're going over bumps and stuff like that. Are we seeing an increase of those kinds of claims and injuries for people doing normal, or what we would think of normal jobs?
Yeah, it's a great question. So look, I mean, I think overall we're seeing an increase in claims for traumatic brain injuries. I'm not seeing them for routine activities. So I haven't seen anything related to, for example, operating machinery, which I guess your bus driving case would fall under. But certainly seeing a lot come through related to industrial and traffic accidents.
Yeah.
And as I think you're implying with CTE, the research is moving fairly rapidly, and that's great. But to some degree, it's made things more opaque than clear at times. And one way of looking at this, which I think is useful, is along a continuum. So you have, a mild concussion. You can have an extension of the concussion over time when we talk about post-concussion syndrome. You can have a mild to severe traumatic brain injury, either closed or open, which is literally the head is either closed or open. And the challenge can sometimes be deciding where on the continuum the person fits. And I think that there are some potential confounding factors. So it's great that there's a whole lot of information on the internet, but Google is not often a great doctor. And so we see patients coming in and perhaps sometimes being informed by clinicians who are not specialists in the area, and they're given these diagnoses. And I think that sometimes it's without good rationale, and it does the person no benefit because they assume that role, read up about it, and tend to conform to that role. And so what we're seeing a lot of is people with concussions and mild TBIs who are manifesting symptoms which are inconsistent with those injuries. And I think we're seeing a lot of people stay away from their lives and their work unnecessarily. And this is where I think that thorough assessment is really important, because from my point of view, often the best thing is to be able to return people to their life and not get them more entrenched in that sick role. Now, that's not to say that we don't see people with severe brain injuries. Of course we do. And that's generally relatively easy to diagnose. It's the grey area around the milder head injuries that I think can be quite challenging. And this is often where neuropsychologists and psychiatrists, in concert with neurologists, can offer a benefit in terms of an accurate assessment and return back to the person's life, hopefully.
Yeah, and that's exactly, I guess, what I was getting at with that question is that the importance of returning back to life. And even with a mild impairment, people can still, I mean, we have neuroplasticity in many ways, and the brain can adapt and rewire, for want of a better term. And people gain the satisfaction, joy, and sense of meaning, I guess, from rejoining society, far greater than sitting on their couch and moping in front of the telly.
Agreed, completely. I mean, I think one of the best prognostic indicators is a person's willingness or not to what I call retire to the couch. And I think we have to be careful with some people not to fuel that, of course, with the best of intentions. But I think that often undoes a person reaching their greatest potential following injury.
Well, look, that is really lovely. I want to thank you so much for making time with us today. You've been able to give some great insight to our clients. And we've got a comment there. Thank you for a very informative session. And I know that this will be valuable to many people who want to know not only a little bit more about you, but also what does a neurologist do? And as you said, the interplay between the subspecialties and the other areas that you work in tandem with. So thank you so much for your time today, Professor Szmulewicz.
Thank you very much, Michelle. Thank you, everyone.
That was great.